I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospital. You might call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies unequaled in the annals of medicine. Of course, this triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and their myriad manifestations. Hence, the idea of these videos. After a short introduction, they will feature a series of images illustrating one or several exemplary cases from my files. Candida infections. Candida stomatitis presents with whitish plaques on the palate and the inside of cheeks. It is almost universal in HIV-positive patients with low CD4 counts, to the point that routine prophylaxis with fluconazole was instituted. It may involve the tongue and outside the mouth, the perioral areas. It causes little symptoms except when the esophagus is involved. These two images show early stages. The whitish plaques detach easily when touched with a spatula. As I mentioned, this stage is usually asymptomatic. With continued immunosuppression, the plaques expand and may coalesce. Two photographs of the involvement of the tongue, Candida glossitis. Fissures called ragades may arise, which are painful. Angular cheilitis, also called Berlèche, due to Candida. Another image of angular cheilitis. Note the coexisting lesions of Kaposi's sarcoma. Extension to the perioral skin. Lesions in the esophagus left resemble those of the mouth. In comparison, cytomegalovirus tends to cause longitudinal erosions, picture on the right. Oral, also called hairy leukoplakia. These are whitish lesions with a corrugated surface, typically on the lateral margin of the tongue of immune-suppressed patients with HIV. They are probably due to Epstein-Barr virus, EBV. However, co-infection with Candida is almost always present, as seen in this insert of a biopsy of such a lesion. As mentioned, Candida is ubiquitous in immune-suppressed HIV-positive patients. Often its pathogenetic role is difficult to establish. Here is an illustrative case. This was a 52-year-old man with severe immune deficiency because of HIV infection, 42 CD4 cells, high viremia. Then he was also treated with dexamethasone for cerebral toxoplasmosis to diminish the mass effect, and he was malnourished with a BMI of 17, an albumin of only 8 grams per liter, and a vitamin C level which was unmeasurable. The picture shows Skin changes suggestive of multiple vitamin deficiency, in particular vitamin C, scorbut, which were aggravated by thrombocytopenia. The patient's chief complaint was dysphagia with an inability to tolerate a nasogastric tube. There were longitudinal ulcerations in the esophagus, both in the middle esophagus on the left and the lower esophagus. And also in the stomach. Abundant Candida were seen in all biopsies. Here we have three different stains for Candida: hematoxylin and eosin on the left, the Gro-Cut silver stain at the center, and the PAS stain on the right. However, other pathogenic agents were found. Here's a picture from the stomach. You see on the left an erosion, and there are viral inclusion bodies apparent, suggestive of cytomegalovirus infection. The suspicion of CMV was confirmed with staining by a monoclonal anti-CMV antibody. See insert. However, other biopsies suggested herpes simplex virus HSV rather than CMV, and indeed staining with anti-HSV2 antibody was positive. See picture on the right. This case illustrates how difficult it can be to ascribe a pathogenetic role to Candida. Indeed, other well-known manifestations of Candida infection are never or almost never seen in HIV-positive patients. This would include nail changes on the left and bacteremia with endophthalmitis, center image, or endocarditis. See a vegetation, a so-called fungus ball on the right. This video is part of a series on opportunistic diseases in HIV/AIDS. I'd be grateful for any feedback that you might have. If you are interested, please subscribe.